Okay, good afternoon. Welcome to CVI 2024. We are in Denver at high altitude, so hydrate yourself and get ready for some exciting talks.
Absolutely.
So I think there are not many formalities. We jump straight into the session. There are going to be panel discussions, and you're welcome to use and stand up and ask questions. So let me begin by inviting Dr. Zachary Rosol, who is my colleague and a very, very talented interventionalist, to talk about couple years into practice, what I wish I knew when I started. Zach, you have something very exciting to tell us.
That's the goal here. So I appreciate the opportunity. Welcome to CVI. I am humbled and challenged to have the first presentation of the conference. So here we go. We'll get started. All right. Here's the cue. This is...
Actually, while we're getting the PowerPoint ready, just to introduce our panelists, we have Dr. Kevin Croce, Dan Kolansky, Ivan Shlofmitz, Allison and Jimmy Kerrigan. So great panel, great insights on how to learn and do PCI. So Zach, thanks so much.
Do I need to turn this on? This doesn't seem to want to advance.
You should be able to hit the slide. Yeah,
This is the slide.
Oh, there we go. It's this one, actually.
No, this is the slide. This is the laser. This is the slide here. This one.
Yeah, it wasn't working.
You
We'll
can go
try.
back.
Here we go. All right, it's working now. So, all right, perfect. Okay, we'll get started. Okay, so my name's Zach Rosol. I'm an interventional cardiologist. This is my path, okay? I'm from Minnesota originally. I went to school at Creighton, go Jays. Back home, down to Texas, where I thought I'd be for 3 years. Back to the Cheesehead State for a year, and now I'm back down to Dallas, okay? I do a lot of coronary work. I also do a fair amount of peripheral arterial work, pulmonary emboli, and I'm learning some more advanced CTO techniques along the way, and I think the key word there is learning. It's always good to keep learning skills as you go along. So here's our roadmap. We're going to talk about the 3 A's to success. I'd like to take credit for this, but actually I learned it at the Sky Fellows course as well from Manish Parikh, and this is my spin on that, okay? So we'll jump right into it. So what are those 3 A's? So here's the definitions to look at, okay? If you can do these 3 things well, I think you're going to set yourself up great for your early parts of your career and in fellowship. So you have to be able to do the skill that you're here for, okay? Being affable means being a decent person and being able to talk to people. That's harder to do sometimes than we think. Being available means being willing to do something and accepting the responsibility to do that. So it combines the able and the affable component of it. So what does able look like in your interventional fellowship? Guys, this is learning by doing, okay? This is an apprenticeship, so you have to start developing good habits right now and keeping those all the way through. And you can't just learn by doing. When you're in the cath lab, come prepared. Get your wide elbows, something I learned when I was in my interventional fellowship. That means keeping us attendings that like to do things as well at bay, okay? You have to learn by having your hands on the wire. Ways that you can stay in that first position is knowing what everybody else is supposed to do behind you and proving that you know how to do the manifold, you know how to prep equipment well, you know the pitfalls. Being able to verbalize what the potential problems are with the procedure as well. I see my guide isn't well. I'm going to seat that better. Oh, I'm going to reposition my distal wire because I don't like it sitting in that small septal branch. If you can start verbalizing that things, it puts all of us at ease a little bit more. We can tell you're understanding what's going on, okay? And you get to do more that way. We're interventional cardiologists. Don't forget about the cardiology side of it, okay? The medical management is just as important as what you do in the cath lab. Don't forget that. Start building your good habits. It's a theme, okay? Learn as much as you can. Reading from journals is important, but really reading and learning how to do this skill is the most important. You'll thank me later if you start doing this last tab, okay? Build your own library of cases in whatever way you learn best. These are my notes down there. I learn best by writing, okay? So when you have a case, go home that night, log it on how you do it and however you learn best. My partner had the Dropbox. That's Chugs, Dr. Brilakis, his Dropbox file, okay? If you start doing this, it puts you at ease when you're off by yourself because you have a case coming up that you know what you're getting into. Okay, great. It's a reference you can look at right before you go into the case. It puts you at ease. It also helps you reassociate that and keep that learning at the forefront, and you'll be that much more confident when you're off on your own. Here's some of those resources that I think are valuable to look into. All right, being a decent person. Talk less and listen more. You're the new person, you're the low man on the totem pole, low man or woman. Stay out of the politics, let your work and your attitude do the talking, and people are watching how you treat other people, okay? So don't forget that. Actually, a point to make on this. Communicate with the people who refer you patients. That means giving them your cell phone if you need to, or reaching out individually and telling them what happened and what to expect when the patient goes back. That shows that, one, you care about their patient, and you're sending their patient back to them to deal with the rest of the medical management side of it. That's how you keep more referrals coming to you. All right, putting them both together, being available. Don't make people wait if you can avoid it, okay? Go meet people before procedures as well. I think this is one of the biggest pieces of advice I got when I was in my interventional fellowship. Meet families beforehand, okay? Complications are gonna happen. You don't wanna go meet and talk with people, and that's the first time you're meeting them when you have to deliver bad news. That's really important. If it shows that you're taking the time to and prioritize those people, okay? And learn from your own mistakes. All right, so we're done with interventional fellowship, right? You come in, you've done your 250, hopefully more cases. You're the master, you just finished your Impella-supported bifurcation, DK crush that you had to rotablate as well, right? Ready to go, everybody's off into practice. Here's the reality of interventional cardiologists in the United States. This data is a little bit old, but I think the trend holds true. 70% of interventional cardiologists, so look around the room, 70% of us will do less than 100 PCI a year. Almost half of the interventionalists do less than 50 PCI a year. And of that, a lot of those are STEMIs, okay? And you can see the inverse relation from number of cases you do to mortality and complications as well. This is gonna be you when you go into practice, and that's okay. Go in with that expectation. You can't be a 250 PCI plus operator right out of the gate. If you are, you found the gold mine somewhere, great, congratulations, but it's just not reality. So control the things you can control, do the little things well, and let your reputation and your work speak for itself, and your volumes and your referrals will increase, okay? So what does that look like in your early career? Keep the good habits going, okay? That's a constant theme, right? If you start to learn to do it well now, when you get off on your own, keep doing it well. Choose your first 100 cases wisely. It's okay to do a diagnostic angiogram and take the patient off the table and find your mentor and say, will you scrub with me, or will you game plan this with me tomorrow, okay? Very few cases, except in the setting of STEMI, do you need to do something right there. So it's okay, and it's not a sign of weakness to take somebody off the table and say, I'm doing this, and you can explain it to the family and have a more educated conversation at that point. I think that's really important, and I think it shows you care, okay? Go into the cath lab with a mentality that you are responsible for everything. It's your name that is there. It's not the nurse's name. It's not your scrub tech's name. You're ultimately responsible for everything, regardless of what happens, and you have to build that environment and that culture with your attitude in the cath lab, okay? Don't be afraid to learn a new skill. TAVR wasn't around, well, it was barely around 20 years ago, but think of where that's come in the structural, okay? The structural piece of our field. There's gonna be new things that come down the pipeline. Don't be afraid to learn new skills as we go along. All right, complications happen, own it. This is why you go talk with families beforehand, okay? And learn to make chicken salad, as one of our partners says. Learn the little things to get the patient off the table and to say when you can stop and when enough is enough. You can't have perfect, especially we don't see many type A lesions anymore. So you have to learn when to stop. And if you do that, you are gonna minimize your complications. This is what your career looks like, okay? Every 6 months, you're gonna feel invincible, you're gonna have a close call, you're gonna take a risk, something bad is gonna happen, you're gonna feel confident again 6 months later, and that cycle is gonna continue. Okay, it's just reality. It's okay to push the risk you take appropriately for patients, but do it within reason. Don't forget to make time for the things that are important. You're gonna have a lot of people that want your time. You have to prioritize yourself, okay? You have to prioritize your family as well. There's always more patients to see. There's always administrators who want more of your time, who want you to do after hours and weekends clinics, and if that's okay and it builds into the schedule that you agree on, great. but you always have family to go home to at night, and don't forget to prioritize them as well. Okay, congrats. It's a dream. Realize it's really cool to do the things we do. It's stressful. Enjoy it, but take it, I would say, do it responsibly as well. That's all I have. I'll say on the back here, these are all credit to Dr. Stoller. I won't go through them right now, but there's just some thoughts for when you're looking for your first job and contract negotiation, so I'll leave it there.
Great job, Dr. Rosol. Great job. We're going to open it up for discussion. Any questions from the audience before we get to the panel? Any quick question? Please stay up here if you don't mind. So, sorry, can't get out of the case before we close the groin.
I've got a question if they don't have a question.
Questions from the panel? Advice, questions, anything? I'm sure all of you have something to say.
You know, Zach, Zach, you speak like somebody who's more than a year out, who's got some wisdom. I think a lot of the things you pointed out are really critically important. We often used to talk about the first 100 cases or the first 25 cases because often if you're new at an institution, you've got to build a reputation.
Absolutely.
And you don't want to be, you neither want to be the cowboy nor the person who won't do anything. So you just want to get in there. And then I think your comments about communication are just absolutely critical. Attendings, referrings, people want to hear from you, and that's really, that's what builds success. And even if you call and say, I couldn't do it, that's okay. People will say, okay, I'll send you another one. I'll give you another shot. And I think those are words of wisdom.
I think the best referral you can get as well, in my opinion, is a family member or a friend, because it shows you that the patient felt like you took time, you valued them, and that you prioritized their health and well-being, okay, and that they felt comfortable enough to send someone that they care about to go see you. And you do that by spending time with people and having open communication.
Dr. Kerrigan, any advice or questions or comments about this?
The only other thought that I had as we were, I'll just hold it down. So the only other thought I had as you were presenting a great presentation and a lot of pearls there with regards to that wisdom. The mentors that you make in fellowship, your co-fellows, also remain great sources of information. So cases, I still have group texts that I may be getting right now from fellows that I train with. Jay Khatri trained me as a fellow, and he's sitting there, and I'll call him at random hours with regards to what would you do in this situation. But then identifying that mentor at your institution, once you do go into practice, who can you run those cases by? Discussing not being a cowboy, but not being the one that shies away from everything. Who can you ask to come and double scrub and help you out in those situations, especially early on in that first 6 to 12 months while you're building the denominator of good cases that went well to develop that reputation as being somebody who's thoughtful, careful, but skilled and able. And then the other thing I thought was an additional A that I like to discuss or think about is accountability too, owning those complications, owning the successes, the wins. Also then making sure to bring the fellows, the cath lab staff into those successes and making sure that everybody feels appreciated and part of the team helps a lot with the team building aspect of things. And that's, you know, in my first 5 years of practice, that's what I've tried to focus on.
Very good.
Dr. Hall, anything to add?
Sorry. Just to come back to the thought of taking patients off the table, further discussion, et cetera. In that same vein of thought, while you can definitely progress what you're doing after you start at a particular institution, you generally still want to be within the scope of practice patterns there when you're starting to establish new relationships with your colleagues. So if you have things in place like rounds where you discuss complex patients for, say, complex PCI versus CABG, et cetera, make sure you do pause and avail of those resources. And then whatever you do, you've come to that decision as a consensus and people will be more accepting of the outcomes. So I think that's a very reasonable approach early on. And it is very key to have good early first impressions. I've seen people come in, even through my own institution, with varied experiences early on, and they really stick with you, unfortunately. So it can be much harder to dig yourself out of that rather than give a good initial impression to begin with.
Okay, wonderful. Thank you so much. For the sake of time, I'm just going to move on. The next presentation is Guide Extensions, and with Dr. Judith Karasonyi.
So thank you for the opportunity to present here today. I'm Judit Karasonyi. I'm a CHIP fellow at the Columbia University Medical Center and used to be working with Dr. Brilakis before. I do not have any disclosures. So first, let's see a short list about why do we use guide extensions. First and foremost, they increase guide catheter support to facilitate equipment delivery. And then there are other reasons why we use them. I will go through this list with examples later on. So the available guide extensions are the GuideLiner, TheraPliner, GuideZilla, Telescope, Guidean, and HeartRail 5 and 6. The original and the first one was the GuideLiner. It has a 25 centimeter rapid exchange section, which connects with a radiopaque marker to a half pipe, and then the distal part is a push rod. This is the basic concept of all of these devices. This is the other guide extension catheter from Boston Scientific, the GuideZilla. It has a radiopaque helical collar to increase the strength and visibility of the device, and has hydrophilic coating. Another concept is from Delphax, the TheraPliner, which is a 2-in-1 device. It has the guide extension part. It's a shorter rapid exchange section, only 13 centimeters, then a short half pipe, and then the distal part of the push rod has a trapping balloon, which could be used to trap wires. It's especially useful in CTOs. From Medtronic, there is a telescope device. They boast with the softest tip. It has a true flex called soft tip, polymer trip, and the other parts of the device are similar to the previous ones. Also, there is the Guidean Hydro from Biotronic. It has a coil embedded shaft with a distal flex zone and hydrophilic coating as well to increase the deliverability. So after the list, we are going on to some tips and tricks. How do we use these equipments? So first, advice is to use the push rod under a towel. So this is a picture from Dr. Brilakis. It's recommended that immediately after you introduce the device, you put a towel and separate it from the rest of the devices, such as balloons and wires, because it could be very frustrating after you finally got into the correct position, and then you try to deliver your stent or your balloon, and nothing goes because it got entangled with the previous equipment. So just make sure you separate it in the beginning of the procedure. Regarding how do you deliver these devices, there are tips and tricks. These are 3 methods how to use them. The panel A shows the distal anchoring, which means that you put a small balloon in the distal vessel and then you inflate it, and then you advance the guide extension. The other versions are the inchworming, which is the preferred method. You use also a small balloon here. You put the small balloon at the edge of the guide extension catheter, you inflate it, and then you deflate it, and at the same moment you advance the guide extension catheter. This minimizes the risk of causing injury, and it helps with the deliverability. Another version of this technique is the BAT, or balloon-assisted tracking. In this version, you have the balloon halfway out and halfway in the guide extension, and you can use it in prior stents or native vessels, but the inchworming method is preferred. Another useful tip is the mother-daughter-granddaughter technique in extreme tortuosity. So here, double GuideLiner technique is used. So there is an 8-French GuideLiner, in that a 6-French GuideLiner, and then you deliver the equipment. So with this method, the case could be solved with severe angulations from a vein graft to the native vessel, as we can see on the pictures. It's also important to keep in mind the compatibility of these devices, because the guide extensions decrease the size of the guide approximately with 2 French size. So you have to keep in mind which equipment fits in which size of a guide extension. And this is the chart for the GuideLiner, but it's very similar to the other devices as well. So let's go back to the reasons. Why do we use these? So the first reason is increasing guide catheter support to facilitate equipment delivery. So this is a case where a patient with end-stage renal disease and hemodialysis came for diagnostic angio, and the diagnostic part of the procedure went well from radial, but then she developed spasm. She was a tiny lady. It was complex to deal with the guide engagement, so we had to use a telescope 6-French GuideLiner to be able to engage the vessel, and then to deliver the equipment, balloons, and then a big derogating stent optimized by IVUS, and we had a good result in the end. Another case shows severe tortuosity and severe calcification. In this right coronary artery. So we went right radial with an AL1 guide, and already with the predilations, we had some trouble with equipment delivery. So we used a guide extension catheter, and with that, and with the inchworming technique, as I described before, you could deliver a distal stent, a mid-RCA stent, and this was the final result after the optimization with IRIS and post-dilations. It could be also used for selective vessel engagement and angiography. In this case, we had trouble engaging this saphenous vein graft, so we used several guides. It didn't work, but in the end, we used a JR4 guide and the 6-French telescope to be able to engage the vessel and then perform the PCI, and this is the final result. It could also be used for thrombectomy. This is a case published in the European Heart Journal, where they had an elderly patient with anterior STEMI and severe thrombotic occlusion of the LAD. They tried to use manual aspiration catheters, which didn't work, and then they finally used the guide extension catheter in combination with a field trap device, which is a basket-looking filter device, and then they could trap the thrombus between the two devices and remove it and avoid distal embolization. Also, it could be useful to retrieve dislodged equipment. This is the courtesy of Dr. Roberto Garbo, where a calcified lesion had the trouble of entrapping the rotablator burr. So then they decided to cut the shaft of the rotablator burr and then advance the guide extension over a wire. And then with this technique, they could retrieve the burr from the coronary artery. It could be also useful in different CTO techniques, such as reverse cart. In this technique, we use an antegrade balloon, and then we inflate it, deflate it, and then the retrograde guide wire punctures the occlusion and gets into the true lumen proximally. This can be facilitated with the guide extension catheter if we can advance it deep enough in the lesion. This is a case where we used it in an SVG RCA aneurysm and an RCA CTO case. The patient had a huge aneurysm, which we wanted to close and open up the native vessel instead. So we went first retrograde through the SVG, and then eventually changed to antegrade approach with a guide liner and advanced the knuckle to the mid-RCA. Performed the guide extension assisted reverse cart, and we could cross with the Gaia third, and then the usual way of externalization happened. We deployed 2 drug-eluting stents. There was a complication here with perforation. We tried to deliver cover stents, but integrate it was not possible. We had to go through the SVG retrograde. And after that, there was also an event with a fractured shaft piece of the balloon. So that was retrieved also with the help of the guide extension. And then we could deliver covered stent to the proximal part. And then the vascular plug was also with the help of the telescope guide extension. And we closed the SVG with that device, and this is the final result of this procedure. We could also use the guide extension in antegrade dissection and reentry technique. It's really important to use it in the proximal vessel, so this helps us decrease the risk of development of hematoma, which could hinder our crossing in the distal vessel with the antegrade dissection and reentry technique. And another unusual application is the cam snare, which is by Dr. Masayaki. He can make a homemade snare with a small balloon and the guide wire. The distal tap is pinned in the guide extension, and then you can modify the size depending on how you advance the wire and back. Guide extensions can also cause complications, unfortunately. They can cause equipment deformation while we are advancing and withdrawing equipment. It's very important to check on fluoro if there is any problem when we are delivering equipment. With the newer generations, it doesn't occur that often anymore, but with the older generations, it was quite a common problem. They can also cause dissection and plaque rupture, so we also always have to check the pressure before we inject, when we have the guide extensions in. If the pressure is dampened, then don't inject. We have to keep the ACT therapeutic during these procedures because the thrombus formation could happen. We have to be careful with distal migration of the device, so always hold it when you're performing injections. Of course, they could fracture as any other device, and they could cause longitudinal stent deformation. And just to go running through this case, it was an RCA lesion where we had a lot of calcification, a lot of tortuosity. We deployed a distal stent, but after that, We tried to post-dilate the stent, but there was under-expansion, and we used the guide extension catheter to move back and forth with the devices, and probably due to this and the under-expanded stents, the proximal stent struts were deformed by the guide extension, so we couldn't remove the balloon. After that, the patient, because had low ejection fraction, had to go to impella support, and we used ping-pong guide technique to remove the balloon. Finally, it was possible with repeated inflations. And then this is the final result, and the impella could be removed. So thank you for your attention. Sorry for going a little bit over time, but it's a long topic. Thank you.
No worries.
Thanks again, Judit. That was an excellent overview of guide extensions. And maybe we start with Kevin Croce. So Kevin, you're using a lot of this. This is one of the most versatile tools we're using pretty much in every day. What are your advice for the fellows, how to use it and when, and any tips and tricks?
Can you hear me? Great. They're the most useful tools in interventional cardiology. I can say that because I trained before they were available. My fellowship was trying to muscle cipher stents down without them. It's a lot easier now. They allow us to do cases we couldn't do 15 years ago. The techniques of delivering them, I think, were really nicely outlined. Oftentimes, it'll take a combination of distal anchoring and enjoyment. We can take these things down to the distal PDA, PLV bifurcation. When we go to train new people in complex PCI, there's a little bit of a reluctance to shove them pretty far down the artery. I think people have read things in the MAUD database where we break these, we dissect, but for the most part, patients tolerate deep intubation of these quite well. You do need to be mindful of the ischemia they cause, so you sometimes have to back it up and put it back down. And when the guideliner is halfway down the artery, don't try to draw an ECT off the guide. It's just going to train air through the TUI. There's lots of little stuff like that your mentors will teach you during fellowship that as we're in July now, I'm kind of teaching my first-year fellows when to not do and do things with the guide extenders. But they're super helpful. Get good at inchworming, get good at distal anchoring, and there's lots of other cool ways of using the CTOs that are probably beyond the scope of July 1. Thanks.
Perfect. And even I know that you've used them a lot of bit for delivering stuff, but also for imaging as well. Any thoughts and any advice from the fellows when to use them to deliver equipment and also to facilitate your imaging and visualization?
Thanks. So I think for calcium modification, this has been a complete game changer, specifically for IVL. A lot of cases that would otherwise be atherectomy cases, just using guide extension catheters help to be able to deliver balloons, particularly IVL distal to the lesion. So that's really where it's become a standard part of my practice. Intravascular imaging definitely plays a role. I think the big thing for fellowship, what's important to keep in mind, just taking a point from the last lecture where you saw the volume that you're going to expect in the future, or at least right after fellowship, your volume will go down after this year. Everyone at a minimum is going to do 250 cases. 95% of you will do less cases the following year, and you're the one who's responsible. So I think the key is you need to get comfortable with these equipment, these techniques during fellowship, and if you're not getting that experience a couple of months in, bring it up to an attending, because they're usually very willing to, if there's something where you have a gap in your training, you haven't been using microcatheters, you haven't used guide extension, when the right case comes up, they'll be more than happy, I think, to walk you through that. But it's really important you get comfortable during training, because it takes a lot longer to learn these skills during your attending practice when you're not doing 5-6 interventions a day.
Wonderful. Yeah, yeah.
Just a quick comment. Know the equipment in your lab. You saw there are 4 or 5 different options here. It's very hard at the beginning to know how to use every one of them unless you're doing 1,000 cases. Pick 1 or 2, get good at them. As Kevin said, learn how to really use them carefully. And also remember that the more equipment you have in a coronary, the more the risk of thrombosis. You mentioned ACT, but we see this, not infrequently. People sort of lose track of you're spending so much time trying to get something down, you lose track of the ACT, you lose track of the ischemia, et cetera. So just pay attention to the rest of what's going on.
I think among the gear points, one of the things that's really critical is if you have guide liners and trap liners in your lab, a lot of people start to forget about the fact that the trap liners are much shorter. And if you're trying to do a vein graft, reverse cart thing or whatever, when you push the trap liner out such that the proximal cuff leaves the tip of your guide, it's really hard to get it back in. And if you pull really hard, you'll fracture it in the artery, and then you have another problem. So if you're going to go really far into the artery, use a guide liner, a telescope, a Guidezilla. Don't use a trap liner, because this short cuff, because we have to have a balloon there for trapping, can make them break if you put them out of the guide. That's one hazard that happens usually with new operators more than sort of you'd want. So, and getting them out once they fractured is a pain, so try to avoid that.
Jay, speak up. Yeah.
I just wanted to make one point related to Kevin's about if you work really hard to take a guide extension deep, be prepared for the fact that the back end may not be your friend. Especially if you go radial, there's a little bit of tortuosity that you have to negotiate, and the back end of the guide extension may not be coaxial with the guide. So if you try to deliver a stent and you feel some resistance, please stop in fluoro, because you will strip it off.
That's an excellent point, actually.
And there's one question from you guys related to this. How about the body wire? The body wire usually going behind this guide extension. Has there been a solution to this? Is there one that is better than others to prevent your body wire to?
You load it together with both the wires.
So if you have, so the question is, can you get, if you put a guide liner or any guide extension that's smaller than the guide, then you have a space, right? So then you should never put, if you put a smaller, like a 6 French guide extension, an 8 French guide, you cannot put a wire through, because the wire likely will go under the guideline. Now, if you have the same size, then it will go, but sometimes it gets damaged. I think what Jay was saying, if you push the wire, it may cut the proximal cuff, and then you may deform your wire. Right. So any resistance, you're going to fluoro maybe to make sure it's not getting caught.
That's it. Excellent.
So excellent. Thank you very much again. You did excellent presentation. And moving on to Dr. Jay Khatri from Cleveland Clinic, who's going to talk to us about calcium modification tools, something that I know many of us, including myself, were very nervous when we first started practicing. But now we have many more tools and much more experience with that. So, Jay, thank you so much.
Manos, thank you for the invite, but I think I'm going to do micros first. Calcium modifications.
I'm going ahead. Skipping steps. You're right.
I can do it in whatever order you like, but all right. So thank you so much for the invite. It's a pleasure to be here.
You got to get the wire down first, so we'll do microcatheters.
Yeah, we'll do the micro first. So what do we use a microcatheter for? So the big idea here is that this is a way of achieving a high level of coaxiality for your guide wire. And why do you want to do that? Because the more support you give your guide wire, the more penetration power it has, the stronger the wire becomes. Even a workhorse wire can be made very powerful if you load it on a microcatheter, because it's now coaxial with a long shaft. It allows a lot of steerability and torque response, which you wouldn't otherwise have. It allows you to exchange and reshape a wire if the wire is not quite the shape that it needs to be, or not the right properties that you want for the lesion. It allows you to inject drugs, or heaven forbid, coils or fat or whatever else to deal with the perforation downstream. And it can also help you with lesion or plaque modification. So all of these things are potential roles for a microcatheter. They're not all the same. They're from all over the world, and just like you drive on different sides of the road around the world, the same thing with the microcatheters. So microcatheters from Asahi have to be torqued counterclockwise. American microcatheters tend to be clocked to advance them. There are some that can be clocked and counterclocked, so it behooves you to try to understand that. There's large categories of devices. There's regular profile or high profile microcatheters. There's low profile microcatheters. There's angulated. There's dual lumen microcatheters. There's devices specifically for plaque modification. And I'm not going to go through all of them. I will kind of make it simple, and I'll highlight some of the ones that I use, and you'll find that as you go out into practice, there'll be devices that your practice has and prefers, and that the cath lab manager wants to keep stocked. So basically, they come in short length and long length, and the short length catheters are typically 135, the longs are 150s. The shorter it is, the more torque response the microcatheter is. The longer it is, it's usually for retrograde. The torqueability is not a given. Some microcatheters are not designed to be torqued. Some are meant to be torqued, so you have to understand that. They come in standard profile and low profile, and you can use these for different reasons. The large profile microcatheters have a lot more push to be driven through a lesion. the low-profile microcatheters can negotiate tortuosity a lot better, so those are things to understand. This is my table. These are the ones that I use, and I'm not suggesting that these are the only ones, but the reason I use these specifically, for example, Caravel has the lowest profile shaft. So I like this for septals. I like this for epicardial. I like this for retrograde. I like fine cross because the inner lumen is 018, so I can do tip-in pretty easily with this. I can deliver coils pretty easily with this. So there are other microcatheters that have very, very small nose cones. And so it's just helpful to understand that there are some fine points to these, but in general, they're small, long, torquable, not torquable, big lumen, small lumen. So torquable microcatheters are great. They allow you to transmit a lot of force, but if you torque them too much, this is what happens. So this is a case where we got overzealous with our torquing, and we unfortunately damaged the microcatheter and it fused to the wire. And when this happens, unfortunately, it all has to come out. And thankfully, this was not a lot of wire and it was integrated, it's no big deal, but this can also happen retrograde. So just be cognizant of the fact that you can do this too much. This is a plaque modifying microcatheter that has a nylon filament on it, also over-torqued, damaged, and the nylon filament came off, but thankfully it was still on the tip of the microcatheter. So just be cognizant of the fact that you can't break these. This is a fluoro save of another microcatheter, which we unfortunately had to leave behind in a coronary artery because the tip broke right off. So just be aware that they're super impressive tools, but they can be broken if you push them beyond what they're intended to be used for. A microcatheter that I've really become a huge fan of, and this is not meant to promote this specifically, but the design of the Mamba and the Mamba Flex is a little bit different because it has braiding that extends to within a millimeter of the tip of the microcatheter. So it's actually very difficult to break this microcatheter. It may not be the most deliverable one, but it's essentially impossible to break it, at least in my experience, so I really like it for that reason. Angled microcatheters are important to understand and use. So there's a fixed angled device called the Supercross, and there's a variable angle device called Venture. They're both really handy for getting around a really angulated bend. So this is a left main bifurcation that had to be rotablated just to make room to place a Venture catheter at the circosteum to make a really awkward angle backwards to get into the circumflex. So a really handy type of tool to have around for these really sort of one-off cases that just can't be wired otherwise. I want to spend a little bit of time on dual lumen microcatheters because honestly, these are probably the most amazing tool for day-to-day practice beyond CTO intervention. There's a whole slew of them that are available. And depending on your lab, you may have twin pass, you may have enhancer, you may have Sasuke, you may have recross, you may have a combination of these. I would tell you one of the biggest distinguishers is that recross and enhancer are trappable in a 6 French guiding system, whereas the others are not. That's one of the biggest distinguishers. Recross is a little bit different than the others because the others are rapid exchange for one wire and over the wire for the second wire. Recross is over the wire for 2 different wires. So I'll show you a couple examples of where I think that these tools are really handy. So one thing that we do use a lot, and I think that everybody should do this, and I first thought this was almost impossible when I saw it, but it's quite doable. This is a hairpin wire, and this is something that we do for really awkward bent bifurcations, and I'll show you a real-world example of it. So basically, you load a polymer jacket wire in the overwire port of either a Sasuke or an enhancer or twin pass, and I usually make a workhorse bend on it, then I make a 20 millimeter bend that's kind of softer, and advance the wire to where the soft bend is just sticking out, and then you'll see what happens when I put that in the TUI. It'll fold over on itself. So that's what you see in this middle panel. So the Sasuke or enhancer is on the rapid exchange port, and then the wire that's meant to hairpin is folding over on itself as soon as it hits the TUI. And this is what it looks like when it comes out of the guide catheter. So when you push this system out and you enter a coronary artery, this is what the wire will do. So you can imagine you're basically doing a retrograde wiring with an integrated system, okay? So where would this come in handy? I'll show you a real case. How do I? So this is an example of where you would use this. So this is an awkward, angulated AV groove circumflex that a prior operator wasn't able to wire, and I'll show you how hairpin wire works. It's a long fluorosave, but I want to show you this on purpose so you understand it's not magic, but it takes a little bit of patients. So this is the dual lumen microcatheter delivering the hairpin wire. And you get this beyond the area of interest, so that tip has to be beyond the bifurcation. So we advance this until we're beyond the bifurcation. And once I have that there, I pull the dual lumen out of the way, and then we just probe. So now I just pull the wire back, and it takes a little bit of trial and error to do this, but with a little bit of patience, you'll see that with just a little bit of just care, you can negotiate these really kind of awkward turns. And we found this to be really, really helpful. And I really encourage you to go home and try this because it's super, super helpful in cases. So there you see we popped in the AV groove. Another device that we use a fair bit now is the recross catheter. So this is for parallel wiring. So we do a lot of parallel wiring CTO intervention. So this is an RC CTO where we're subintimal with our first wire. And with a recross, which has 2 over-the-wire ports, we can seesaw back and forth. We can change wires back and forth. So the first wire is subintimal, and we bring a second wire down to the other port, and the second wire starts a barber pull around the artery. And so at this point, you would think stingray, retrograde, whatever. But honestly, if you haven't created a hematoma, you can come back. So what we did is we left the second wire in position and exchanged the first wire, went into REO, and now you can see we're going to thread the needle of the calcium with the first port. And you can see it negotiates nicely. And then on the right panel, you'll see that I think I've lost control of my... Is it because I'm out of time? It won't play anymore?
No. It's
okay.
That's a subtle way, but that's not what it is. But
so I have no control of this mouse. Is somebody in the back able to play that?
Forward?
No, I can't control the mouse.
Yeah, click outside and then... Let me try this.
The light's not even on the mouse.
Wow. Okay, just say what you have to say.
Well, you see that we cross in the right panel. So can somebody in the back advance the slide for me? Another trick that we really do a lot is blunt cap puncture using IVUS. So you can put a Boston Scientific IVUS down a side branch and load a dual lumen microcatheter on the same wire, so an enhancer or Suzuki on the very same wire. It'll butt into the IVUS, and basically the side port will show you where the image is, and you can use that to image the cap. So in the inset on the right, you can see the IVUS is in the RV marginal, and then you can see a penetration wire in the proximal cap of the CTO. So a really cool trick that we use quite a bit now with the dual lumen microcatheter. So next slide, please. So in summary, I would tell you that the main purpose of microcatheters is to achieve guidewire coaxiality that improves torque response and the power of the tip of the microcatheter. There are some very specific attributes that these microcatheters have. Some are braided, some are not braided, some are torqueable, some are not, some are long, some are short, some are low profile, some are long. You need to understand all of this stuff, and then you need to figure out what you want to stock and have on inventory in your lab for your specific clinical needs. Okay?
Thank you, Jay. Hang tight here. A few questions. I think I have a great suggestion. You saw Jay has a lot of fluoro saves in his presentation, and I think it's a useful thing to do, is to be able to review these. So I'm going to go to Allison, maybe to Jimmy after that with a few questions. So these tools, both guide extension catheters and microcatheters, cannot be just used when you absolutely need it. So how should a diagnostic fellow aspiring to be an interventionalist or a new interventional fellow start using them when it is absolutely not necessary? So should they wire a side branch? Should they wire, I'm being very serious about this, should they wire a side branch that could easily wire using a dual lumen microcatheter and see how it works? Should they play with it outside? Does your lab provide that? They should see it under fluoro and fluoro that device. What do you do in your training programs to actually make sure that they are facile with it and the case itself, where you absolutely need it, is not the first learning ground for it?
So that's an excellent point. So I'd say it's a combination of things. So first of all, when you talk about playing with it outside of the body, actually, I think that's really important sometimes. So if your lab has ready to expire equipment or something you pulled out in a case that you didn't end up using or what have you, just ask if you can take it home with you and you can play with it on the table and get a real sense of how it works. That can be helpful to understand concepts before you use it within the patient. For simple microcatheter use for wiring difficult branches, wire exchange to get a sense of trapping, you could really try that in any situation. You could try it in an extremely straightforward, say, RCA PCI, just to get the concept of trapping and exchanging your wire. But if you want to get a little bit more skilled with it, absolutely, I agree, using for side branch access, whether that's a single or dual lumen microcatheter would be a great scenario to use it in. Those angled circs, we all have to deal with them, and you'll encounter some of those in your fellowships. So it's a great scenario to use an angled microcatheter or dual lumen microcatheter. But in basic day-to-day practice outside of complex PCI, I often grab microcatheters in STEMIs too, sometimes when the lesion is just a bit more refractory to crossing and I need to take a different wire. Quickly exchange with a microcatheter is another scene that you might be able to practice in. But absolutely, you don't want to wait until you have the hardest possible case in front of you and you're struggling, you don't know how to use the thing. So getting hands-on exposure to it outside the body and then practicing in simpler cases, absolutely.
Allison, I think the STEMI example is huge. So I think everybody should use a dual lumen in a STEMI, just so you can give some drugs downstream without losing wire control. It's a great way to have a good reason to open a dual lumen and get your hands on it and feel it and understand how it works.
In the same vein, I was thinking back to Judith's case with that right coronary with the JR4 guide, where a guide extension saves the day in that situation, and then it got stuck, but we won't talk about that part of it. But using it in those situations where you're really struggling for guide support, may not have picked the right guide from the beginning, and then as Allison said, using it in cases where it might not be absolutely necessary, rewiring a side branch through a stent for a bifurcation strategy. If you're struggling with a jacketed wire, just put a dual lumen microcatheter down and use that opportunity. And then talk to your reps, not only expiring equipment in the lab, but the representatives from the companies who make this have models, they have demo equipment. They're always happy to show you how to use those tools and technologies outside of the body or on simulators before you have to do it in the body. But suggest it, especially if you see somebody struggling with straightforward or in personal practice, pulling it before we get into that struggle.
Great talk, Jay. Thank you very much. I have one final recommendation, just a precise one. Learn to use these devices outside and maybe then share it with the scrub tech who will be scrubbing with you. It'll be a repetition for you to build teams, and then they will be in sync with you, and you will be able to answer questions. There is no better way to learn something when you actually teach it to someone else. So with that, let me invite a great teacher and a dear colleague, Dr. Brilakis, to give a talk on Guidewires. Manas, what have you recently discovered about Guidewires?
Turns out you need them for PCI before you put calcium modification. So the reason you'll see me do a bunch of talks today is not because it was planned, it's because people canceled. So I'm just filling in for several people who had some last-minute emergencies. Do you mind just putting, oh, it's up there, perfect. So wiring, as you've heard, is a critical step. There's one device that you can use without a wire. This is the crossboss catheter for CTO that you push without a wire, but pretty much for everything you need to put a wire in, all the equipment that we use. So wiring is a critical step for PCI, and it can be achieved in 10 steps, and I know many of you have suffered through this. But the first step is that a microcatheter is needed or not. And from Dr. Khatri, you heard already, the microcatheter can really make a big difference because it changes the stiffness of the guide wire tip, it changes the characteristics, makes manipulation much easier, allows you to exchange guide wires, so it's something very important to consider, even in cases where you may not think it's important. Now, if you spend 10 minutes and you haven't crossed a lesion, then you should put a microcatheter. So just because sometimes you use another wire or you spend 10, 15 minutes, if you cannot wire a lesion in 5 minutes, I would say you should use a microcatheter that will make your life much easier. How do you think of a guide wire? It is not a piece of metal. My original idea is that it's just a thin metal you put in the coronary. Turns out there's much more engineering to it. There are different characteristics, like how stiff is the tip? Do you have any coating on the wire? How thick is the core? And this is an example of a guide wire. This is an Asahi shear wire showing you that actually the wire tip is a very intricate piece of manufacturing. It has multiple coils that go around the central part of the wire. So you have this central portion of the wire. You have a lot of coils coming up in various configurations. You have small inner coils, you have outside coils, you have further outside coils. So this means it's not a piece of metal, it's a lot of coil, and if it gets caught and you pull hard, you may actually unravel the coil and create problems, as you will see in the complications course. This is one way I like to think about guide wires, which is more a functional classification about when to use what, which is probably what we use more in day-to-day practice. There are the workhorse wires, which are soft tip. Soft means 1 gram, forced to bend it or less. And sometimes they do, or sometimes they don't have a hydrophilic coating. They can be out of nitinol or stainless steel. Sometimes they have different constructions to make them more torqueable. But these are the wires you'll do the vast majority of your interventions. Why is that? Because the risk of perforating a vessel is much less with this wire. Number 2, you have the polymer jackets. These wires have a coating, but this is not the same as the hydrophilic coating. This is a very, it's a very lubricious and very thick coating that makes the wires slide. And then you have wires that we use mainly for CTO PCI. These are the wires with a stiff tip that are designed for penetration. Fourth category are wires who are supportive, meaning the body, not the tip anymore, but the body is actually fairly strong, it's fairly thick and gives you support delivery equipment. You have wires to do atherectomy. These are thinner than the wires we use for standard PCI. You have externalization wires when you do retrograde CTO PCI, and the Persu wires for the FFR and the various non-hyperemic indices. So these are the wires that you use to get through the lesion. These are the wires that we use for delivering equipment. So once you deliver, you cross the lesion with the polymer jackets and the stiff tip, those have to come out. These are not wires to deliver equipment because they can puncture, dissect, cause many problems. So you take them out over a microcatheter and you switch for a workhorse or a support wire or an externalization wire. And then again, you have the ones for specific functions, atherectomy or retrograde CTO PCI. Now, when it comes to workhorse wires, there are many brands out there, and you can try different ones. My advice has always been, in fellowship, try everything. Whatever is in the lab, try it out, because some things you may enjoy more than others, and some, the attendings have a very strong preference. Once you train or learn something, you have a very hard time changing it, and wires is one of those things. A special case of wire, this is called the SU03. This is a 0.3 gram wire used for going through tortuosity, complex tortuous vessels. This is like a workhorse, but it's used for very soft lesions. Also in SCAD, if you have a dissection, this is a nice wire to prevent going under the dissection plane. How do you shape the wire? It depends on the diameter of the vessel. This is one way to do it, which is through the introducer, which I prefer because you have a lot of control. This is, I would say, a more common way where you just put the wire and you brush it on the side of the introducer needle, which makes more smooth curves, but the problem is it can be very large. You have much less control on how you shape them. There is always the concern of advancing the wire if the loop gets, if the tip gets looped. But actually, having a loop in a wire, in a soft wire, may not be that bad. This is a case where the wire wouldn't go, but the looped wire went, and having this loop prevents you from getting into side branches. This is something about going through tortuosity. You heard it before, sometimes the wire prolapses, so you can either find a different wire that is less likely to prolapse, or what you can do is get a microcatheter. This is the Super Croce that is preformed. You pull the wire, you pull it back, and now you can advance the wire to go through. So having these devices can really help you, the microcatheters help your wire go where you want to go. In terms of the polymer jacketed wires, there are 3 subcategories based on whether they are tapered and whether they have a higher tip stiffness. Cyan black is one of the non-tapered ones. You see this vessel and you should send them for bypass. However, if for whatever reason you decide to tackle this, even a long time ago with less capable equipment than now, you can actually advance a microcatheter and a polymer jacketed wire through this degree of tortuosity. When it comes to the tapered polymer jacketed wires, these are the ones we use for CTO. This is typically the #1 wire we use when trying to approach a CTO, and this is when you have a nice tapered entry. If you have a stiffer or a calcified entry, you may want to use a stiffer wire. There are variations, the Fielder XTA and Fielder XTR, there's the Fighter, there's the Bandit, but all have the common characteristic of a tapered proximal end. This is what Dr. Khatri showed you in a schematic. This is pushing in the looped wire. When it comes back, that's how it hooks the vessel. Then you get a microcatheter, and then you can remove the guide wire, and then you can advance a workhorse wire through it. Or you can do this with a dual lumen. You get a wire down the vessel, then you get a dual lumen microcatheter. You advance the wire. You can actually form the knuckle inside the vessel. You pull back the dual lumen microcatheter. And now you rotate the loop, and as you're coming back, this wire wants to unravel and gets into this part of the vessel. When it comes to the stiffer wires, those can be fairly aggressive. These are the pilot wires. These are wires that are less likely to prolapse, so sometimes we use them from tortuosity. But I would say in the majority of cases, we use them for CTO and complex PCI. This is an example where the wires prolapse into the circ, but this has this parabolic grind and actually was able to go to the LAD without prolapsing into the circumflex. These are different variations. Mongo is designed with a weak point, so you can make these tight knuckles. And the Raider is another stiff guide wires. I won't go much into those stiff wires. The Asahi desk is back. You can go over them. These are CTO wires for going through heavily calcified vessels. You sometimes go up and then you go down, but be careful in tortuosity because the wires can go out. There are things like the Ultimate, the Gaia wires, the Gaia Next guide wires, and again, very elaborate construction. The Judo wires is a similar category of wire. These are the Spears, the Confianzas, the Hornets, the Astatos. Again, these are for CTO. Please don't use them during your fellowship unless supervised. And then finishing up, the support wires are the ones you deliver. Ironman, Grand Slam, the Wiggle is a special one, has these curves, can get you off stent struts. Atherectomy wires are thinner than the other wires, either for rotational or for orbital atherectomy. Externalization wires are also thinner, and of course we have the pressure wires. So to summarize, these are one way to think about guide wires. You should be very good in your fellowship looking at workhorse, but also know about the polymers and the other wires, especially the support wires, to use when needed. So thank you so much.
Manos, thank you so much. As always, you're unbelievable. Well, let's go to the panel here, and maybe start with Dr. Kolansky. I don't think we're going to be able to teach wires in 2-3 minutes, but we have 3 days of good lectures. So let me get to the other aspect of this. I know that at least in my hands, usually I'm the one who picks the wires, and Manos is right, and I've been using the same wires for the past 15, 18 years. What do you recommend to fellows? They come to this course, and Manos is like, well, use different wires, get experience with different wires, but they're at the mercy of the attending. What are the ways that they can convince the attendings or work with the attendings to help them be able to utilize other wires and get other experiences?
Well, wires have clearly changed and evolved and improved since many of us started in this business. And I think that applies every 3 to 5 years. There are definite incremental changes. You showed some today, Manos, and just even old version, new version of the same wire, and they get better. And so they get a little safer. Now the potential for harm is there. So I think you need to approach the cases in the lab and say, look, we want to get some experience with newer wires. Remember, it's also in the operator's hands. It's not just the wire. So you take a new wire, even if it's got new characteristics, as long as you're careful, the chances of harm are small. And so it's really, I think you say, listen, we need to try some new things in the lab. Wires have evolved. Let's try it. Let's just be careful. And it's really in the operator's hands. So I think that's a really good point. One really quick other point, if I may. I think the microcatheter thing has changed the game a lot. When we all started doing roto, I exclusively wired with the roto wire. I think everybody exclusively does it through crosses with something else and change with a microcatheter. So it's a good way to get to learn microcatheters, is to, as was talked about a little bit earlier. But so things change and evolve. I think we have to be ready to try that.
Yeah, Ivan.
Yeah, I was just going to add, I think a good opportunity to convince an attending to try out one of the other wires that might not be their workhorse. Bifurcation PCI, you're going to wire with their workhorse wire in the main vessel, but a lot of times people are open to using a second wire for the side branch. So if you mention looking to see the difference of a second wire, bring them an example, and usually as long as it's reasonable, they'll be open to it.
Manas, I have a question for you. Maybe the audience can also raise their hands. There are two ways of wiring, with a hand and with a torquer. And I want to start this debate here so no one feels that we are all in consensus, because inciting debate and discordance is part of our theme. Is that right? So raise your hands while Manas is answering that question.
So
You
how
come
many
from
people
cath
use
lab.
a torquer
Yeah.
when you wire a lesion? How many people don't? Don't the attendings slap your hands yet, or? I can tell you in our lab, half the attendings will slap you. If you not use a torquer, they slap your hand.
This is a serious question. In terms of tactical feedback and learning the wire, is it better? I mean, I use a torquer, but could I have been better if I used my hand all these years? I mean, this is a real question.
Depends how much you work out, Dr. Banerjee, and how strong you are, but...
That's a good point. But
You know, I mean, I think there's a role for both. I mean, if it's a straightforward PCI, you can probably get it without. When you do Stingray, you need a torquer. When you're doing some complex manipulation, I think the control is better with the wire, but especially in the complex circle, and Jay can correct me if I'm wrong, there are some very strong opinions, and some operators, Kevin knows, will refuse to put the torquer on. I think, you know, use as you see fit.
But I have a real serious point that sometimes it is worthwhile, both from Jay's and other presentation, to use some of these devices and wires outside the table. It gives you a better feel and allows you to rationale. And the other thing is that whenever you're attending chooses a wire, ask them the rationale to pick it. That insights, that puts that grain into your mind and allows you to make those decisions. So, sorry, Mehdi, I took over your time.
No, I agree with you completely, and I would add one other thing is that learn wires from other attendings and then bring it to the attention of the attendings that are not using it. And I'll be honest with you, I'm not a CTO operator, and my fellows come like Xi'an, blue, gray, yellow, and they drive me crazy. I'm like, okay, well, let's use it. What can I do? You know? Anyway.
Yeah,
All right, we're gonna
fellows
move
are
on.
like bees that go from room to room and pollinate new things. And you have to understand, someone with me, like me that has gray hair, I have really bad fear of missing out. So FOMO is a great reason, like, hey, Jay's using the Xi'an XYZ yellow today, and I'm going to want to try it just because Jay's cooler than I am. So certainly have the ability to reference what your other attendings are using, and maybe you'll get a chance to try them with someone that only uses a BMW in the current era.
Absolutely, BMW, that's right, and Pro Water. Okay, we're going to go to balloons now, and Dr. Kevin Krause, thank you so much.
Thanks. So I was going to give Manos a hard time for probably giving me the most boring topic in the entire afternoon, so I'll try to make it interesting. I know he loves me.
Make
so
it interesting, that's you.
So to make it interesting, I stole a couple slides from his amazing book, which you all should read early in fellowship. And so wiring was before me, and now lesion preparation is next. And the most simple way to prepare a lesion is obviously with a balloon, and Jay is going to get into atherectomy. Lesion preparation goes through a device progression from simple, cheap, and easy, such as balloons, through all sorts of stuff, which Jay is going to cover in detail. And there's lots of different types of balloons. They're not just boring, compliant, non-compliant. We've got lots of different versions of them, small ones, plaque modification ones, trapping balloons, osteoflash, drug-coated, very high pressure, and Jay, I'm sure, will cover IVL, so I'll skip over that. Just very quickly about standard balloons. You know, compliant balloons will grow in their diameter faster or larger as a function of pressure. And with that, we use these to predilate gently and to address stent malapposition. I'll show you a picture of that in a second. Non-compliant balloons are higher strength, and they can handle overinflation pressures, and they grow less. And they tend to, you know, by the law of Laplace, sort of grow at the edges less. And so that's why we post-dilate stents with them and use non-compliant balloons to deal with resistant lesions. This is an example of both an underexpanded stent and one which has malapposition. If you were just going to deal with the malapposition, you would want to take a compliant balloon so it can just gently grow into the artery wall and press the stents up against it. So it's just one example I had in terms of when a value proposition and the characteristics of a compliant versus non-compliant may be useful. This has been transformative. I was trying to get Abbott in Boston to get OPN in the United States for many years, and finally they came as a sole source vendor to the US. And this is a very high pressure balloon, which is rated, I think, to 35 atmospheres, but I can tell you we can routinely take it to 40 and 50, and it rarely ruptures. This is for very difficult to dilate lesions. We use it in our stent failure practice for the most part to deal with underexpanded stents. Laser on contrast, shockwave, drilling out a stent with ROTA to an OPN has really made life a lot easier. Before this, we were taking angiosculpts to 30. They're only rated to 24. They would rupture from time to time. And so these very high pressure ones, painful to deliver, A little hard to get out of guideliners because they don't wrap well, but they can be really, really helpful for instant restenosis, which is underexpanded. Some examples here: multi-layer, double layer, triple layer, laser on contrast to an OPN at 46. You can see by the stent boost eventually they release. And so these have been really, really helpful for us for dealing with resistant in-stent lesions. In Europe, people do use them for native arteries. I tend to like an atherectomy or IVL first. I don't like putting 50 atmospheres of pressure on something which hasn't been modified. I think the risk of rupture is certainly higher than I'd like it to be. We tend to use them mostly in our stent failure practice. Small balloons are really helpful. There's a lot of different kinds of these. The ones that we're partial to are called the Takiro and Sapphire. Takiro comes in 1.5, Sapphire comes in 1.0 and 1.2. Sapphires are really nice because they deliver. They're also a little bit painful because they tend to rupture more. They're our preferred granuloplasty balloon because they like to rupture. Granuloplasty is the option of taking a balloon to high pressure, getting it to rupture to try to modify a plaque. These are really useful in a scenario where you have a wire across and nothing else will go. I think I have an example of that next. Easy circumflex CTO done radial. A Pilot 200 sails through it, and then none of my microcatheters want to course through. And so at this point, there's a really nice algorithm, which I won't have time to go through, of what to do when you have a wire across a lesion and nothing else will go. A guideliner can be helpful because you can push further. Add a microcatheter, which Jay already talked about, and you can maybe add a microcatheter with teeth, one of the ones that are the plaque modification. And small balloon with progressive inflations is where these Takiros and Sapphires can be useful. And down the line is laser, subintimal plaque modification, lots of fun CTO stuff we won't go over. So I tried that. I added a bunch of microcatheters, spent about $1,500. None of them would go through. I tried a small balloon. I was not able to get it to go through, but I was able to wedge it in. Your attendings will ask you can't get something to go through. Do you want a long balloon or short one? You'll know already you should take a longer one because many times the fattest part of the balloon is a marker wire. You want to edge as much material into it as you can. So with that in mind, I still couldn't get a turnpike through. I used a laser, and eventually we were able to get stuff to go, and we were able to treat this. And so it's just an example of wire across gear won't go. It's something that you should be cognizant of. The plaque modification balloons are really of threefold. Angiosculpt has nitinol wires on it. Cutting balloons has razor blades, and chocolate is kind of a combination of wires that are built in pillows. These are nice because they tend to lock into lesions. Very helpful for ISR. Very helpful when your balloon won't stay put and it tends to watermelon seed. Focal osteal LED, it's always a pain when the balloon sort of slips back and tries to damage left main. So these are nice because they'll lock into the plaque and have stability. They also have a focal force pressure effect where either the blades or the nitinol wires are able to augment the pressure on a resistant lesion. This is one example for the Wolverine, which is the cutting balloon version. You get about 3 times more force focally where the blades are compared to a regular one. You're going to cover shockwave, right, Jay? Awesome, I'll skip that. Skip this. This is sort of a lot of calcium by OCT. Orbital didn't work. We shockwaved it. We were able to get a good result. I'll get past that fast. Trapping balloons were alluded to before. The idea here is if you have a 180 millimeter wire and a microcatheter at the end of it, your wire is not long enough to pull it off without losing wire access. The way we ameliorate this is to just put a balloon up at the tip of the guide, pin the wire, while the microcatheter is proximal to it, and then you can just pull the microcatheter off. A lot of people that don't do CTO PCI are not proficient with trapping. It's really, really easy because I joke with my fellows, if you take a 300 centimeter long wire, they should sell it to you with an alcohol swab for when it falls on the floor. They also torque less well. They're painful to manage. Please get good at using short wires. I think it's really, really rare they have to use a long one in our lab. Most of the wires we have are short, and it's been facilitated by trap liners shown earlier or by these trapping balloons. There's a couple different kinds. Trapper and Trapit are the ones we have in our lab. It's important, though, if you start trapping, as soon as you let the trap down, when you pull the microcatheter out, air will go into the guide. You have to kind of bleed it back and make sure you get the bubbles out, because the last thing you want to do is in your first day as a new attending is inject air down someone's LED because you're trapped on a microcatheter. Osteoflash balloons are very, very helpful. We probably use 2 or 3 a month. They are a double lumen balloon, which has a bulbous portion here and is able to press stents into the wall at the ostium. And leaving stents hanging out like I've shown here in this cadaver study we did with the Osteoflash team is really painful, because if I do this at 2 in the morning and STEMIs and stuff, and then Jay has to come back a couple of years later and treat the patient, he's going to be pretty mad at me when he can't engage his guide. By using this Osteoflash, we're able to compress the struts and actually get good malapposition and good coverage of the ostium. This is what it looks like in this cadaver study. You sort of press it along and flare it like a trumpet. This is a painful example I had from our brachytherapy program. The last person to treat this patient had 5 guides to access from the radial because the stents were hanging out in the aorta so much. We were able to get a wire through the side strut, stabilize the guide, and I took a second wire which went luminal. This is sort of a good trick. If you're stuck in a situation where you can't get the guide to seat coaxially, Just stuff any wire down there which stabilizes it. You can back it up and then try to wire it luminally. With that in mind, I won't belabor the IVUS. If you look on the right panel here, you can see that the stent is hanging well into the aorta. And so with that in mind, we were able to get a cutting balloon, an OPN to 50, got this thing to expand well. We treated it with brachytherapy, and at the end of it, I osteoflashed it just so we wouldn't have to deal with this again. After the osteoflash, you can see the stent protrusion is completely better, and so we're able to engage very easily now. God forbid the patient has to come back again. And so I think, could you advance to the next slide, please? Great. Drug-coated balloons will be covered a lot at this conference. These are approved for use in the United States for in-stent restenosis. Our colleagues in Europe use them a lot with small vessel disease and CTOs and in really lesions that we prefer not to put stents in because the failure rates are quite high. This is going to be transformative, and it'll be neat to see where this goes in terms of how our practice changes over the next several years. This is the most exciting thing I think that's come out, at least in the past 5 years in my mind, in the complex PCI space. So with that in mind, I'll go back to Manus's original example of these are all the balloons. Have an idea of what categories, which ones you have that fit in these categories, and how to use them. Thanks for having me, Manus. I hope I made it interesting.
Can I just ask a quick follow-up about the OPNs? They're new to most of us. They're just coming across. So 2 questions. One is, when you're doing a complex second, third layer, do you ever just do it with the OPN and don't have to do the laser and the multiple steps? That's the first question.
Yeah, so the intravascular imaging is mandated for all stent failure cases. And we have enough experience because we treat so many of these. You can tell by the amount of calcium, the monolayer, and sort of what it looks like by IVUS or OCT, whether it's going to be a primary OCT case. The problem with an OPN at 50 is you can still cause a perf, and we've done that with lots of these stent failure cases. So I kind of am more inclined to try to change the compliance. I like shockwave and laser on contrast because it kind of does it in 360 degrees. So it can release gently as opposed to you pick the weak spot and just rent it into a hole. And the worst thing is to have 3 layers and have to put a papyrus in it. I've done that, and it's kind of painful. So we still have a fairly plaque modification heavy to OPN approach because it feels like it's more gentle from a perf standpoint. I can't prove that, but that's the way we've sort of measuredly gotten after this in the current era.
Second question is, are you using it for anything else besides?
Yeah, the guy who runs the company is like, hey, Croce, you guys are the biggest user in the United States, at least when it first came out. He's like, I'd like to hear about how you're using it because, maybe it's going to replace IVL. I'm like, we only use it in stent failure. So I have to say, although we use a ton of it, it's because we have so many people referred to our brachy program. I don't have a lot of comfort with going 40 ATs in a native lesion unless it's been modified, although they do have data apparently coming from Europe where it has, reasonable efficacy in difficult to dilate lesions in natives. I haven't gotten there in my practice yet, but I'm interested to hear Manus or other colleagues that have it. Jay, if you guys do something different with it in natives.
One thing that I find it helpful for, it's similar basically because I've already got a stent in there, but say it's acute stent placement, but I'm not entirely happy with the expansion. I find it works pretty great in that scenario. And I usually undersize it slightly as well and then go up 36 to 40.
You've had it in Canada for a long time, right, Allison?
I have.
Allison has way more experience than I do with it. Yeah, awesome.
No, I think you're right. This is actually I think we'll hear more about this in the meetings. A lot of cases that it happens. The one thing is if you use it, probably familiar with this, just use a body wire because sometimes it gets stuck and there are only some certain wires you want to use it over so it doesn't get fixed on the wire. But that was actually, I thought it was the most exciting talk of the session so far. So thank you so much, Kevin.
Manus, I want to make one comment. Sometimes there is a tendency of using a over-the-wire balloon in lieu of a microcatheter. I think the risk with that is that you can actually fold or compress the balloon lumen, and once you've gone distal, you may not be able to pass the wire. So, and you can even, if you try a stiff wire, you can even penetrate the shaft of the balloon catheter. So I think, I've seen it a few times, I think that long over-the-wire balloons in difficult lesions are not a substitute of microcatheter, in my opinion.
It's a great point. I always joke with our fellows that the failed CTO PCI that was done elsewhere and then referred to us for us to do is typically an over-the-wire balloon in a Miracle Bro 6. You'll notice a Miracle Bro 6 was not listed on Manus' slide because that's a very old CTO wire. So the comment I'll make is, oh yeah, over-the-wire balloon in a Miracle Bro 6, it's a multivariate predictor for a failed CTO PCI. So it's a great point. It's not the modern way to do stuff.
Another comment on the OPM balloon, do not use it with a Xian blue. unless you want to remove everything as a unit, because they will fuse. You
I
just
was
can't.
just going to say that I completely agree, and not only for OPN, but repeated high-pressure inflations on NCs.
Yeah.
I use that wire a lot, and I'm having a lot of regret because it happens very frequently. So.
Yeah.
Or a buddy wire is not a bad thought. I might try that.
Super. Okay, great.
Finally, your talk.
My talk. I'm up next. Okay. Do I have control of the mouse back? Yes. All right. So now we're going to talk about calcium modification. Thankfully, Kevin's already covered most of this, so I can be a little bit more just conceptual in my talk. Why do we want to modify calcium? Ultimately, we know that if you can improve lesion compliance, you're going to get better luminal gain. If you get better luminal gain, the procedure is much more efficacious, much more durable, and hopefully a little bit more safe as well. If you have to really hammer on a lesion because you didn't correct the calcium, there is a significant risk of dissection or perforation. Modifying the calcium can help to facilitate the subsequent procedure. Delivering of microcatheters or balloons or stents can become much easier once you've modified the calcium. Debulking of the calcium can help with access to side branches. You saw that on my earlier talk about the left main bifurcation. We actually had to rotablate the left main simply to gain access to the side branch. And I would say that the biggest take home is that intravascular imaging is critical for all of this. There's no way that you can understand how much calcium there is and whether or not you've actually modified it or not without intravascular imaging. So that's paramount. So what do we use this for? We need to understand how deep is the calcium. We need to understand the arc of the calcium. We need to understand the thickness of the calcium. We also need to understand the length of the calcium. And all of that data is important in terms of determining how best to approach the lesion, because there's a lot of options. And this is a really helpful algorithm. I encourage everybody to put this in their phones and refer to it from time to time. It's a consensus algorithm, which I didn't participate in the writing of this, but I couldn't agree more with this. So everybody take their time to look this up and try to understand exactly what they're saying. But ultimately, what you need to do is image to understand how much calcium there is. If you can't even get an imaging catheter down there, that's a problem, and you probably need to perform some sort of atherectomy and then image. If you can get a 1-to-1 NC balloon down there and modify the lesion, confirm that with IVUS before you move on. I won't go through the whole algorithm, but it's a very thoughtful way of approaching this. That being said, with this, it's still very hard on a day-to-day basis to understand what to do. And I'll share a case example for the remainder of the talk to explain to you just how challenging this can be. The mainstay of treatment is an NC balloon. The problem with an NC balloon is that it's going to expand in the area that's soft and not in the area that's non-compliant to calcium. So if you go up high enough and big enough with an NC balloon, you will eventually tear the artery rather than modify the calcium. The idea with cutting balloons or scoring balloons or Angiosculpt or Scoreflex or chocolate, these balloons have metal elements on the outside. They act like a fulcrum. So imagine you have a stick in your hands and you're trying to break the stick. It's really hard. But if you put the stick on your knee, it's pretty easy to break it. That's the idea of having that metal element. It gives you a fulcrum to apply more focal force. And the more elements there are, the more chances you are to interact with calcium and potentially modify it. And so that's the idea there and why there are so many different designs on the market. The simplest thing to do is to put multiple wires on a coronary artery in an NC balloon. You have a bunch of cutting elements now. So that's the most basic way of doing it, and there's all these fancier devices that are available. And then the most exciting thing over the last 5 years, I would say, is IVL. The interesting thing about IVL, though, that I never really thought about it, I used to think that the force of the IVL was in a 360 ring, but actually this is also directional, and depending on the way the balloon is sitting, those waves of energy may or may not interact with the calcium, as you can see in the cartoon on the right. So even IVL, you can actually move it back and forth a little bit to have a little bit more chance of interacting with the calcium, particularly if it's nodular. So what about atherectomy? So rotational orbital are the two options, and they have overlapping rules, and some labs only have one or the other, and I think it's interesting to debate this, and quite frankly, we have both. And I would tell you that the one thing to understand about rotational atherectomy is that there's a predictable interaction with the artery. So the wire bias will make the burr interact with a lesion. The diameter of the interaction is fixed, okay? The burr only spins. The issue that I have had personally in terms of problems with orbital atherectomy is that not only does the burr spin, centrifugal force will allow that burr to start to orbit in a larger diameter. So the longer it sits on a lesion, particularly a calcified lesion that's tough to cross, the more time it spends in one spot, the bigger the orbit becomes. And you can't always predict that. And that's potentially a possible avenue for a complication. So just be aware of that. That's one big difference. They're very similar skill sets, and I think that they both basically do the same thing. There's always a debate about whether for right coronary, whether you need a temporary pacer or whether you can use aminophylline. We like to use aminophylline, but that's another technical point. So I'm going to go through an actual case just to illustrate just how tricky this can be. This is a patient that had a remote LAD PCI, had an acute coronary syndrome last December at an outside hospital. They tried to treat the culprit vessel, which is circ. Apparently could wire, but could never cross, and so they aborted the procedure. Went on to see us, had angina, had a PET scan that showed a lateral wall ischemia, had a recath that shows that the circ now is a CTO. So that's what we were sent. So this is in the left panel what we started out with, a very short segment CTO that was crossed with a polymer jacket wire pretty easily. And we intentionally decided to go ahead and rotablate because we understood that they were having difficulty delivering equipment. And so when you have difficulty delivering equipment, the first thing I think of is let's sand out a path with rotational atherectomy. The burr would not really go much past this point. It would start to decelerate. And if you force this, it's going to get stuck. So we decided to stop, okay? So this is what we see. So panel A, IVUS, is just the ostium of the circ. Not bad. Panel B shows a nodule of calcium that has not been modified at all by the rotational atherectomy, mainly because it was decelerating there. And then panel C is the distal landing zone, looks nice and healthy. So we decided to go ahead and wing it after testing the lesion with an NC balloon. So I put up a 1-to-1 NC balloon, go to burst pressure, and then I do a rotational angio where I'll swing the C-arm back and forth to look for any constraint in the balloon. And if I don't see constraint in the balloon, that's sort of a surrogate for, okay, the compliance is adequate to expand, and we can go ahead and stent. And we went ahead and stented. I mean, all of this seems logical and reasonable enough. This is the stent going up. And so this is what it looks like. So I put the IVUS down just to see what we had, and you'll see here that where the nodule of calcium was, the stent is grossly underexpanded right here. And so that's annoying and very disappointing, and despite our thoughtful efforts to do this correctly, we didn't. And I wanted to just share this with you because this is not easy. So then we went in with an IVL balloon and treated that nodule with IVL. Probably should have done that from the beginning, but we didn't. But that seemed to do a good job at expanding that area. So this is the subsequent angiogram and then the IVUS on the right panel. Now you'll see that the nodule is still there, but at least the luminal gain is a lot better than what we had achieved before. And so we went from 4 square millimeters to 5 square millimeters, which I think is good enough for this size of a circumflex. So in conclusion, I would tell you that calcium modification is critically important to optimize both the safety and the effectiveness of PCI and calcified arteries, and that balloon-based strategies should be your initial approach. Balloon-based strategies aren't always going to work. Balloon-based strategies may not be deliverable. In that case, you need to have atherectomy. You need to be facile with the device. You may have orbital. You may have rotational. You may have the choice of both and understand that. You have to understand the risks and benefits of one versus the other. And the last point I would make, and the main point I want you to go home with, is use intravascular imaging. Without it, you really can't do these cases. Okay?
Awesome. Jay, I want to draw attention, and the panel can chime in, to 4 very important words that I want everybody in the audience to hear it again. The word nodular calcification. The second word is wire bias. And third is orthogonal views of calcified lesion, because you can be fooled. So I don't want to emphasize it, but go ahead. What happens and how can you detect wire bias? Do you always have to do imaging, or angiography can help? And the panel can chime in, please.
Well, the whole point of wire bias is that's going to predict where your device will interact with the lesion. And a nice way to understand where that's going to happen is to put an imaging catheter down, because you'll see where the image is adjacent to the wall and where it's floating in the artery, and that will tell you where the burr will interact. I think that's what you're getting at.
Yeah, because many of those complications during ballooning and during atherectomy can happen because of unrecognized wire bias. So generally, nodular calcification can be a big boulder, but the remaining of the arterial wall can be less calcified. So the burr and the balloons are going to hyperextend the normal area. So I think if there are ways to identify, it's a very big challenge, and that's why I invited all the experts on the panel to chime in. It's not an easy solution. Go ahead, please.
Well, and that's a situation where using the wire bias can help us solve that problem. If you have a calcific nodule on the inner curvature of the right coronary going distally with orbital, for example, that has bidirectional cutting to pull back and allow you to use that wire bias to cut into it, versus using a stiff rotowire versus a floppy rotowire, potentially to take advantage of that as well. Or with the case of lithotripsy, looking at the wire bias inside the balloon, like Evan and Ziad have taught us, to wait until that centers in the balloon to know you've modified the calcium. So use that in order to make sure that you're doing a good job in modifying the plaque, not just creating a carriage cart on top of or around the nodule or the calcium.
Intravascular imaging is essential anytime we're treating calcified lesions, but in addition to intravascular imaging, there's advanced fluoroscopic tools, things like device detection, stent boost, which really are invaluable with calcium. Every single balloon inflation, you could really see if there's under expansion and if you're getting the compliance change that's necessary there. And that helps to save steps so you're not doing 12 different intravascular imaging runs. So use that liberally.
And that,
The other thing about nodules, which is super painful, is much like the case Jay showed, sometimes that stent can't hold them open. And so it is the main reason why you can get acute stent fracture when you just place one. And in several cases a year, we just have to put a second stent in because despite being deliberate orthogonal views, a lot of orbital rotoshock waves, sometimes these things just don't open. And we tend to use high radial strength stents. I don't know if you guys have thoughts on that, but you'll put a regular stent in and it'll just compress under the force of these things. So they tend to be a major point of pain, which is why I think you probably bring it up to be aware of.
Yeah, and I think that I want to finally emphasize, and Jay speak to it, and we all speak loudly about it, is that a lot of information can be gleaned by carefully studying the diagnostic angiogram. I think it is a key attribute and a key point before planning a calcific lesion treatment, is very carefully analyzing and thinking through those steps, and like Zach said, writing them out or proposing to learn it. So I want to throw a credit to Paul Sorajja, who is busy on his phone, that he's the author of this term, Operators Enclave. And what Jay said and other presenters, are we really living up to it? Are you getting technical pointers that will truly transform this meeting into something that you gain necessary pearls of wisdom on how to practically engage with the cases? Is that, you don't have to answer it, but it's something to think about, and that is the whole focus. And all of these presentations will be available on our website.
Can I ask one question from Jay or Kevin related to the issue of pre-dilatation? When I was training and in my practice, I always went with a 2.5 or even sometimes 3.0, but definitely 2.5. And I see a lot of the operators use a 2.0 balloon. What is your advice in regards to, because I always envisioned the pre-dilatation, and you showed in a nice orthogonal view that you did to show that the balloon is dilating. So the pre-dilatation for me has always been, is the lesion going to give before I put the stent? What's your advice in regards to the balloon sizing for pre-dilatation, Jay?
That's a great question. So I would tell you that you can use whatever balloon you want to pre-dil if the idea is just to make space for imaging, okay? But once you have image or have a sense of what your ultimate stent size is going to be, pre-dil again with an NC that's 1-to-1 with that artery and do those orthogonal views to understand if your stent's really going to expand or not. That's how I do it.
Yeah, a well-expanded 2.5 balloon in the Prox LED to then stent is fool's gold.
Exactly. Awesome.
Okay.
Awesome, Jay.
Okay, so Darshan Doshi will talk to us about what to do when things don't go well. Snares, coils, cover stents, so when you lose things or when you have perforation, what can you do? So 8 minutes, he'll cover it all.
All right. I don't know if this is a badge of honor or I'm being publicly shamed to give this talk, but nevertheless, I'll be talking about snares, coils, and covered stents. So we're going to start off with a case. This is the first case. So this is a case of a patient that came in with unstable angina, was found to have a lesion in his prox to mid circumflex, which you can see. It looks like a straightforward lesion that I think most people would feel comfortable tackling. There are a couple of issues that I think kind of dovetail from Jay's talk. One, the lesion is calcified, and it's hard to appreciate that on the angiogram. The second part is that it's a retroflex circ, so getting any sort of equipment is difficult. So a guide extension was used, and ultimately the lesion looked like it dilated appropriately, and then subsequently a IVUS catheter would not pass, but the operator wanted to proceed with a stent. The stent would not pass the lesion, and the stent was pulled out. Now, what you can see is that the stent really wasn't pulled out. So you see a remnant of a stent, but you don't see a balloon. And moreover, you see that the stent is actually, unfortunately, accordioned. So what you see here is the following. So this was the circ, and essentially there's a stent, and the distal part is stuck in some calcium, and it can't be freed. Then the stent is not only just in the circumflex, it's now also in the guide. And the operator tried to put a second wire, balloon, and try to free it up, but unfortunately was unable to do so. So how do we get the stent out? So this is something that unfortunately will happen during the course of your training and most likely during your interventional fellowship. So this is my algorithm for stent loss, and it's really predicated on whether or not the wire access is maintained through the stent, yes or no. So if it's not, then the three main options are to snare it out, to stent exclude it, or to leave it alone, depending on where it is. If you have the wire access, you have a lot more different options. Snaring it, stent excluding it, you can deploy the stent, you can put small balloons through, and then dilate it, and then subsequently deploy the stent. Or you can get a balloon past it, inflate the balloon, and then pull it back to get it out. Or you can use multiple guide wires distally, twirl it, and then kind of lock it, and then pull it back. So the name of the talk is snaring, coils, and covered stents, so we'll focus on snaring. So this is a schematic pulled from Manos's Manual of PCI. And essentially the way it works is that you're going to have to put a loop of a snare on the wire if you have wire access. And that wire, the loop is also connected to a microcatheter. A microcatheter can allow you to open up the snare and also tighten it and cinch it and then pull it out. This is a quick schematic from the Euro PCR site. And essentially, this is how it works, where you have a snare with a microcatheter, and essentially you then pull the microcatheter back to allow the snare to sort of open up. You then subsequently have it on the stent, you cinch down, you push the microcatheter forward to try to lock it in, and then you try to pull it back. Okay, and that sometimes the angulation is not appropriate, so you just have to change the guide, if possible, the orientation of the guide to allow it to go through. So if you do that, then sometimes it'll go through. Alternatively, you can use another guide with a much larger caliber to be able to snare this out. So there's different types of coronary snares. The three most commonly used are the micro snare, the end snare, and the micro elite snare, made by different companies. The micro snare is more of a gooseneck snare. It comes in 2, 4, and 7 millimeters, and the catheter size is anywhere from 2.3 to 3 French. The end snare is more of this tulip shape that you see. That is a much larger, so it's usually to grab larger things. When we used to do CTO PCI, when we didn't really have guide extension, the way we would snare, what we would do to try to externalize would be to snare the wire. And then more recently, Teleflex has a micro elite snare, which just has a button at the end. You don't need a catheter, so as a result, you can get it, you can use the loops to get in where it wants, and you can press the button at the end to just sort of grab it and pull out. So the micro elite has probably been much easier to use compared to the other two. All right, so what was done here? So essentially, we had to use a ping pong guide and then had to get a wire through the vessel using a different guide. Ultimately, got a snare down, used the snare, and just in the interest of time, we were able to snare it out, and this was the final result. All right, let's go to the second case. This is a patient who's a dialysis patient who had angina during their dialysis sessions. And what you can see is train tracks in the LAD. This is the caudal view. And these are the cranial and the spider views. And what you see is an LAD that looks like dental floss down the middle of that coronary. Now, the patient had chest pain that was thought to be attributable to this. So the thought was to take care of the prox and then see if we could open that up. And so ultimately, a small balloon inflation was done. The balloon really didn't expand. So then we went with atherectomy, went with a 125 burr to create space. After the 125 burr, we did pre-dilatation, used IVL, and then subsequently deployed 1-to-1 size stents. Okay, so then we post-dilated, okay, and everything looked like it was going well. We did the last post-dilatation, and as things happen, it's always the last post-dilatation. And this is what you see. So here you have a big perforation. So now the question is, what do we do? So aside from staying cool, you have to figure out how to manage this. So there are different types of perforations. There's a type 1, type 2, and type 3, and then there's a cavity spilling, also known as type 4. It's the type 3 that you really have to worry about. Type 1, you can usually leave alone. There's no issues. Type 2, depending on how extensive it is, you may or may not need to do something about it. Type 3, usually you need to do something about it unless it ends up going into a cavity. So there are a couple of risk factors that are associated with coronary perforations, but usually calcium, tortuosity, elderly age, female gender are the things that typically tend to portend perforations. Now, this is a fantastic algorithm, again, from Manos's Manual of PCI, so this is a recurring theme. If you haven't read it, please read it. But it's essentially, what do we do here? So we knew that this was not just going to stop with balloon tamponade, and a covered stent was most likely going to be needed. So in the US, for the longest time, the only covered stent we had available was the GraftMaster, which was a PTFE stent. It was only 6 French compatible and was very hard to deliver. More recently, we have the PK Papyrus, which is 5 French. The GraftMaster was a stent sandwich, so it was a stent, PTFE, stent. PK Papyrus is a stent with just PTFE on the with polyurethane on the outside. So it's a much lower crossing profile and more likely to be delivered where it needs to go. The VAS sizes 2.5, 3.0, 3.5, and 4.0 can be delivered through a 5 French, and then the larger 4.5 and 5.0 require 6 French. So here, what we did essentially was we put a balloon up to stop the bleeding, tap the patient, which is, you see the pericardiocentesis kit going. And then we wanted to see if that helped, if the balloon tamponade helped. On the left, you see the hand sign, so you see that there's active chest compressions taking place. And then subsequently, we were able to get some control, but not great, delivering the papyrus. So we just post-dilated it appropriately. And then ultimately, this was the final result. The drain was taken out a day later. The patient left the hospital in 72 hours and did well. All right, last case, I know I'm running a little late, but this one will be very quick. So this was a reverse cart that was done for an RCA CTO PCI. At the completion, what you see at the tail end of the PDA is a wire perforation. So this wire perforation, we tried to observe, just thinking it'd be okay, but it continued to grow and grow. So with small wire perforations, you can treat it with a bunch of different things. So coils are typically my choice for treating distal wire perforations. And there are different types of coils. There are neurocoils, which are much smaller and can go through your regular microcatheters. Otherwise, you need to use a much larger microcatheter for other types of coils. So the Axiom Prime by Medtronic are the coils we have and we like. And so as you see, the coil is coming off at the end, and then you have a specific tool as a detacher to detach the coil, which is what was done in this case. No issues, no problems. The patient went home the next day. So what you need to know during your fellowship is that you're going to require some, if not all, these tools at some point in your interventional career. You don't want to use these tools when you absolutely need to. You want to have some practice with them beforehand. So industry as well as hands-on programs are, I think, very important. And then you want to practice things in safe settings. So coiling vein grafts after CTO PCI can be a great way to learn coiling. And the other part is you need to know where these devices are found in your cath lab. You don't want to be searching when time is of the essence. So thank you, and I'll stop there and take any questions.
Thank you. Thank you so much, Dr. Doshi. That was awesome and a lot to cover in just a few minutes. So going to the panel here, let me start by Dr. Kolansky. Can you, again, I want to focus maybe a little bit the questions around, preparation for the fellows. Can you discuss a little bit about when you have a complication, what's going through your mind? What are the steps you are thinking in your head beyond just the fact that there is a complication?
Well, it's a great question. I think, as somebody mentioned, the first step is to keep cool and realize that we have a lot of tools and we can generally solve it. And the other thing is, so the first two rules are keep cool and ask for help, because those are the two things that will get you out of a jam. And sometimes you need a set of hands to do something like CPR, sometimes you need a set of hands to help get another access, and sometimes you just need a head to help you think through the options. So keep cool and get some help. Those are the first things I'm thinking about.
That's great. I definitely agree with those, and I think that getting help, don't be too overconfident in thinking that, oh, well, maybe I can get through it. I don't want anybody else to know about the complication because everybody will know anyway. So you might as well, call for help early on. Let me ask Jimmy. Jimmy, your recommendation, I loved your suggestion about knowing the tools. How do you keep up with them in a sense that, like coiling, for example? I think that's probably the one that we are the weakest in because we don't do it as much. What is your recommendation in regards to, keeping up with some of these technologies or at least being familiar with them so that, when you need it, you at least have some familiarity with it, especially if the rep is not around and so on and so forth?
Yeah, so Darsh touched on this at the very end, which is regards to purposeful practice. So if you have an opportunity to coil a vein graft after doing a CTO intervention, that's a great opportunity to learn coils. If you have access to go to interventional radiology where they use coils not infrequently to fix bleeding vessels, that's an opportunity as well. We've also switched to neurocoils. The Ruby LP is what we use to go through any 014 microcatheter, which is born of an issue getting a prograde down for a larger Terumo Azure coil. Attending conferences, listening to presentations, paying attention to representatives from different companies, walking through the back of the room, the exhibitor floor, to try to figure out what the tools are that you have, both at your current institution and where you're going and how to use those. The detacher handle might be different for the EV3 versus the penumbra coils or et cetera. So making sure that when it comes time to do this at 2 o'clock in the morning, and it's always 2 o'clock in the morning for some reason, at least in my experience, that you don't have to have somebody else there to tell you what to do. Same thing with covered stenting, which is not currently indicated for the treatment of aneurysms inside vessels, but we do it because you have to at certain times. That's a good opportunity to use the covered stents in those situations, become familiar with deliverability, making sure that you don't strip them otherwise as well. So I think that being purposeful with the practice, working with representatives, attending courses. There's a great course coming up in a couple of weeks in Seattle focusing only on complications, where there's a lot of hands-on. So attend that at some point during your training or early in your career, if at all possible. And then tomorrow a session on complications as well. But watch others do it and learn from our mistakes.
Dr. Hall, any advice? Sometimes there is a complication, and I see some fellows are very eager to get in there and get involved, but others shy away because they're like, well, maybe they don't want me there. Maybe, there is too many people. And what advice do you have for fellows when there is a complication? Should they scrub in and get in there even though they're not part of the case, or should they stay out? What do you suggest?
So that's a tricky one for sure. I think some of that comes down to being able to read the room and to present yourself in a sensible fashion. So I think you can certainly come in and when the timing looks right, offer your assistance and just note that you're available, you're happy to help and happy to assist with the use of any of the equipment that we just talked about, or even to observe if that's not getting in the way. But you do have to be somewhat, cognizant of the entire situation if the patient is crashing and you need certain people that are immediately capable of dealing with it. But it's very appropriate to step in and try to, kindly invite yourself into the situation as long as it's going to work out.
Thank you. You want to make a comment?
I want to. I think the vascular surgical program, the Society of Vascular Surgery, has started a dedicated program to help deal with the stress and trauma when a complication does not end the way we anticipate it ending. And I think this is an important question because I think each institution should establish workflow processes where debriefing is part, it is done in a supportive, and the operator in that situation or the fellow is not left to fend for themselves because it's a very, very traumatic thing to do. And I think we should speak about it. At our lab, I can tell you, and Zach is here, there is a small group in service going on continuously. So it doesn't disrupt the flow of work, but whether it is IFR wire connecting IVUS, coils, extension, there's a continuous in-service where equipment is taken out and it is practiced with the team because it's not only important for you to know what to do, it is important to know for the person who scrubs in. So I think these are important areas which our field has yet not touched. But I don't want to put you on the spot, but are there any formal ways is this difficult situation addressed at your institution?
Yeah, so unfortunately, we don't have a dedicated pathway, which I think is lacking in our, I think we need guidance from our societies, and we have to formalize pathways to be able to take care of this. I think that, you know, M&M can sometimes be helpful, but sometimes it can be very punitive. At our institution, at least the culture is such that after there's a complication, we try to support the person that had that complication. We, you know, hug them, make sure they're okay. And then when they've, you know, fully processed and healed from it, then we do a deep dive and figure out how it can be prevented or, you know, if there are mitigating circumstances that transpire that resulted in it. So usually you start with emotional support and then not really delve into the nitty-gritty until the person is ready to discuss it. That's at least how we try to tackle it.
There's a lot of work in this, and I'm glad you brought this up, Subhash, by the way. There's a lot of work in this area with zero harm and learning from defect and fractional learning and so on and so forth. And honestly, those days of, you know, the senior attending yelling at you and I mean, we got to stop that kind of nonsense. And, you know, we are all here to learn from each other and improve, you know, the care of the patients. And we all make mistakes and have complications. So I love your idea of, you know, debriefing after a complication. I really think that that's eminently, and then obviously later on you have an M&M and you get into the details.
And let me reaffirm once again what Mehdi and Dr. Doshi just said. That when we mean debriefing, we do not mean M&M. Right? And we can take it outside this forum and discuss how it should be at respective institutions, but it is critically important that our programs have a pathway of dealing with this. It's very, very important. And it is not only important for the operator, it is actually important and critical for the growth of the program. No program will progress if such a process is not well established. So thanks so much for bringing it up.
I'm going to end with one more. I'm going to end with one more question because I think it may be important, and I was going to ask Evan if you don't mind. We talked about early on call for help and, you know, be readily humble and get some more people to help you with the procedure. Can you comment about, you know, who do you ask for at the later stages? Meaning that at one point you say, okay, call the surgeons to come. It's one thing to ask for help with, like you said, you know, with CPR, with, you know, bringing another access point, you know, for another guide or because you have a perf or something like that. But when do you escalate to like ECMO and CT surgery and other things, you know, where should be the threshold for that kind of a help? And do you have like a stages in your mind, a protocol, or how do you approach it?
Yeah, I think it's good. The sooner you call, the better. It doesn't mean that you're sending the patient to surgery, but I usually will stop for a second if I'm thinking that it might escalate and end up needing surgery down the line because you get into a complication, whether it be cardiac surgery or vascular surgery. Usually it's good, call them, let them know what's going on. They'll usually come up, check out the patient, make sure they have a room available, and then you proceed with what you have, but at least you have that backup plan in place. And then just leaning on before, aside from just people in your own institution to run things by, a lot of times you're going to find yourself in a small hospital where you might be the only interventionalist there. If it's nighttime, you're the only interventionalist. So, you know, build your contact list of who you're going to call in case of emergency, basically, where you get into a challenging case, you stabilize the patient, and while they're on the table, you may break scrub, you know, take a picture, and it could be your attending that's your mentor, it could be a colleague that, you know, is a CTO operator, but everyone has that person that they reach out when they get into a challenging case, and it's really helpful Particularly, it's a very global network, so there's always someone who's up at, on a different time zone, so that's always helpful too. It doesn't have to be support in your hospital.
Great points. I think that was an important point of calling early is always better because those folks are not sitting in their office just waiting for you to call them. So please be mindful that it takes time for people to get down and to come and to help you. So with that, I'm going to call on our last speaker of this part one of the complication session, our colleague, Dr. and friend, Dr. Manos Brilakis, hemodynamic support. Manos, thank you for stepping up and covering Dr. Khaldoun Al-Sawad.
So, the lesson is what you saw from Dr. Doshi, don't post-dilate very much your stand, because then your colleague may have to do your talk. But, it is what it is, and the reality is even in the best operators in the world, you're going to see this happen, and actually hemodynamic support is one of those things that can really help you when things don't go as well as you would like them to. So we do have a lot of devices available. The balloon pump is used less now, but it's still available. The impeller, most commonly used to have ECMO.
I'm sorry.
God, everyone is excited. I love it. But there are two questions every time you do a case. The first one is, do you need to use a hemodynamic support device? And the second question is, if yes, then which device should you use? And there's the algorithm. And that's, one way to think about things, but the way to start about hemodynamic support is to start with hemodynamics, because the whole idea is hemodynamic support is to support the patient's hemodynamics. Get the worst case scenario. So if you have cardiac arrest, then there's one solution, that's ECMO. Then you need a full heart lung machine, the patient is going to die otherwise. So there's no question here. But the questions, of course, happen when you have less severe hemodynamic derangement. So let's say you have a patient with cardiogenic shock, then it depends on many parameters, if there's hypoxemic or not, if there is right ventricular failure or left ventricular failure or left ventricular failure alone. And if you have hypoxemia, then you may have to go to ECMO. If you have isolated right ventricular failure, you go to the RV support devices. But if you have left ventricular failure, most of the time now you use an impeller. As you know, Danger and Shock came back earlier this year, and now there's some strong data that impeller support in acute MI with cardiogenic shock can actually improve survival. What happens if you have normal hemodynamics or you have mild instability? And you're going to ask, okay, how do I know the hemodynamics? And this is one of the key points. To know the hemodynamics in any patient with either baseline heart failure or low ejection fraction, or when you're starting a very complex PCI, it may be best to just do a right heart cath. I know this is usually the case you whine about, like, oh my God, the right heart cath, why me? But in cases like this can really save the patient and yourself from a lot of trouble. So the patient comes in, has no heart failure, you're going to spend 5 minutes, you get your numbers. If your wedge is 40, then what should you do? Exactly. You call your heart failure team and let them deal with it. Use your support. I mean, this is the best way. Then they come to you 2 days later with a wedge of 12, and it's a different game. And they're happy, you're happy. But you wouldn't have known that if you didn't do the SWAN, because sometimes those patients, especially in Midwest, you may have these massive patients. Okay, is this edema? Is this subcutaneous? It's hard to know sometimes, right? So the SWAN, no questions. You know exactly this is the wedge, this is the array, you know exactly what to do. Could you go to the next? I think it's got, there you go. Now, if you have a patient with cardiogenic shock, then this is another form of support. You can do CPR either with your hands or with devices like the Lucas device. And then if you have abnormal hemodynamics, then the question is, what is the PCI risk? If you have a very low risk procedure, isolated type A lesion, then you might be able to do it without support. But if you have a high complex lesion, then you might want to use support. And how do you determine the risk of PCI? Depends on the location of the lesion. Is it the left main? Do you have a lot of calcium towards calcification? And what are you going to do? So if you're going to do a atherectomy, if you're going to do retrograde PCI, if you're starting with a lot of thrombus, then your risk obviously is going to be much, much higher. So for cases like this, you may want to have support, but if you have normal hemodynamics, normal PCI risk, then you may be fine otherwise. So let's say you want to do PCI, you decided to do hemodynamic support, what is the device you're going to use? And in the vast majority of cases, it's going to be an impeller. There are some cases where you cannot use impeller. if you have LV thrombus, if you have a mechanical aortic valve, if you have severe AI or you have a VST, again, not very common, but important to know. You don't want to go in the ventricle with a big thrombus there. But also you have to have arterial access to get the big 14 French sheath in. And if you don't have a good femoral access, then do you have an alternative access, whether it is axillary or transcaval is another option. If not, then sometimes you can use just a balloon pump, but otherwise you're trying to go for an alternative access. The two more commonly used devices I mentioned before, it's going to be the Impella and VA ECMO. In terms of the Impella, again, there are specific steps you want to follow, and it's good to not to skip steps because things can happen. There's sometimes you forget to pre-close, and then there are ways to deal with this, but it's much easier if you do it in the beginning. You want to get your access and get the two per-closes, 10 and 1 o'clock, and get some good sutures around the femoral artery before you put the device. Some of the most tricky points is to get the Impella sheath in. Always have a picture, an angiogram afterwards to see if you have any flow. If you don't have flow, it's usually okay during the PCI because the leg will tolerate ischemia for a few hours. But if you're going to leave the Impella in, then you're going to need some form of perfusion for the lower extremity. You either go from the other leg and you put an undergrade perfusion sheath on the Impella sheath, or you can do this from radial access, or sometimes even through the ipsilateral access through the side arm of the Impella sheath. And then you may have seen that now we can do single access PCI. If you use an Impella, you can puncture the Impella sheath and put up to a 7 French sheath. And through that sheath, you can do your PCI without having to obtain a separate access. Be careful when you do that, because if you need to move the Impella, or when you're moving the cover, the sheath and the guide, you might dislodge the Impella either too deep or too shallow. So be careful of that so you don't get any complications. Same thing for ECMO. ECMO, how many of you have done ECMO? All right, it's about half. So hopefully you'll see many of them. I think it used to be a much more niche procedure 5-10 years ago, but now increasingly most programs are having access to ECMO. And the way to simply think about it, this is you put two sheaths, one venous and one arterial. Now these are big sheaths. These are 15 to 17 arterial, 25 venous. These are huge sheaths. But then you put the sheaths in, you connect to the machine, and that's it. So conceptually, it's a very simple procedure, but because the size of the cannula that you're putting in, then you want to be careful on how you obtain access and how you do the connection. So you use stiff wires, you use dilators to dilate the groin, and then when you go in with this big 25 French venous sheath, you want to make sure on the back that you are holding the dilator, because otherwise, when you're going in, the dilator may be dislodged, and then you may have some issues. So you see that the dilator is being held in place while the ECMO cannula is going in, and you do the exact same thing for the femoral access. And after you do this, the most stressful point is this, when you're now ready to connect, and you don't want to have any bubbles. And imagine the Lucas is going on, this is a controlled situation, but sometimes it's not. So what you have is someone putting some saline on both sides, and you're going to fill both tubes with saline and then connect them without having any bubbles. You check them again. If there's a bubble, you may have to disconnect and reconnect. And once you do that, you remove the clamps, you start the pump, and now you can relax. To do your PCI, get the swan and everything else, the patient is going to be supported. So this literally can be a life-saving device. I can tell you there are several cases, CTO complex cases, the patient causing complete arrest. If you don't have access to ECMO, the patient is not going to make it. There is no randomized trial yet showing that ECMO saves lives, but I can tell you in the cath lab, in some cases, no question that it does. So being familiar with these devices, having access to these devices can really help you both prevent complications, but also track complications if you happen to have them. So thank you so much.
Manas, stay there. You know, I and Mehdi were talking that next year, Manas, we have to have a session of endovascular skills for the non-peripheral operator, because there is no better way to address this. And I can tell you, and Mehdi can disagree or agree or chime in, there are 3 important pivot points that I will tell you will determine the success of your mechanical circulatory device. Number 1, patent inferior mesenteric artery. Manas made a comment that if there's a tight lesion in the external iliac or in the common iliac, your leg may tolerate ischemia that happens because of collateral development from the inferior mesenteric artery. If it doesn't happen, you have to anticipate of getting antegrade access. And for antegrade access, you need to be prepared with a sheath that does not kink, because putting in an antegrade access with a soft, regular 6 French sheath is not going to provide you antegrade access to the leg. And a leg ischemia in a patient with cardiogenic shock, I think it's game over. So that's one. The second one is presence of a stent or previous stents in the iliac arteries. Manas? I think that's an important point. That is very, very important.
I can show you a good way to take them out if you want to.
And the last point is that if you need to have a covered stent implantation, you need to have a compatible guide wire. Remember, many of your peripheral covered stents don't go over 035 wire. So if you have such a complication and you have to switch the wire between the case, and iliac perforation will not be redeemable at that point. So I want to invite others. Mehdi, you have so much experience with this. Any other pointers you want to give for MCS-based peripheral complications?
So I guess you'll have to come next year again, sorry guys, to see the next one. But.
Well, I mean, I think that the one point I think that's important is that please remember that your colleagues, even as friendly as they are, like I said before, maybe it's my experience, they're not readily available next door to run in there to help you, meaning your vascular surgeons, your cardiac surgeons. So your ability to deal with your complications eminently is going to be lifesaver for the patient, but also for your own mind and palpitations and hair loss and stress and longevity. So I think for that reason alone, it would be a good idea to have some skills to get you through some of the complications, whether it's mechanical or related to PCI or other things, because that 5 minutes, 10 minutes, sometimes 30 minutes, while you're waiting for your vascular surgeon or cardiac surgeon to show up is going to be a long, painful 5 to 30 minutes.
Like a lot of this is learnable and has been boiled down through organizations like this into algorithms. And so many of us will keep these things on our phone because at 2 a.m. if you're alone and, you know, Manos presented a great algorithm on how to deal with a perf when the wire is not across. You're terrified, you're wishing you did dermatology fellowship, you're probably tired, and you forget this stuff. And so, you know, phone a friend is the first thing, but also just kind of a lot of the stuff that will happen to you that makes our jobs give you gray hair like mine is predictable. You're likely in the 20 or 30 years you practice to have a wire exit, learn how to use coils. You're likely to have a large vessel rupture, learn how to get a covered stent in, use how to get a guide liner to get it down there so you don't strip them off, because the worst thing is when the papyrus falls off the balloon, which they tend to do. So a lot of these things are teachable. That's why, as I think, you know, Jimmy mentioned, the complication course is great because it's just meant to kind of go through the algorithms that have been built by people that have gone before us to help us to be able to deal with these things. And MCS is another one. I would argue if you're putting impellers in routinely, you better know how to go up and over or go radial to femoral just to get a balloon up. You may not understand the compatibility of what Viabond fits on what wire or what sheath. You should in time, but at least just putting an 8.0 balloon up in the common femoral and buying some time for your surgeons to get there and your partners is transformatively life-saving for patients. And so through some of the courses that Manos and I have built together, we have kind of a laundry list of non-peripheral people should know these basic things, how to get up and over, what the toolkit is, what the steps are. And similarly, there's a similar toolkit for, you know, CTO techniques that can really bail you out of difficult non-CTO cases. And so as your career grows, and hopefully during your fellowship, you'll start to assemble some of these concepts. The first perforation I had in the first year attending, I drove a rotaburr through someone's right coronary artery on a Saturday morning. The only reason that woman lived is 3 months before I went to the Sky Fellows course and someone had taught me how to put a ping pong guide up because I was alone. And so I was so thankful for the guy that showed me the slides and happened to take a lot of notes. I think to the point Zach made earlier, take notes on stuff that matters like this, put it on your phone, have it as a resource.
There's this rule that, you know, whatever you see in the course is going to happen to you in the next 3 months. Just saying. So pay attention. Anyway, thank you. So we'll just break for 30 minutes, and then we'll be back with the continuation. Thank you so much.
Awesome.